The pressure volume loops are an important way to understand the cardiac cycle and some important concepts in cardiac physiology. It's a really nice graphical representation of every cardiac cycle and gives us an understanding of how left ventricular volume and pressure are related. So first, let's take a look at this from a 30,000 foot view. This graph is only worried about left ventricular volume and left ventricular pressure. This is a graph that is focused on the left ventricle, the moneymaker, the powerhouse of the heart. When we look at this, we can see that there's a loop. Each one of these loops from point A to point A all the way around represents one cardiac cycle. So an easy way to look at this pressure volume loop is to start at S1 over here on the right side. S1 we can think of as the beginning of the cardiac cycle. It is the beginning of systole. Systole begins here at S1, shoots up over the cardiac loop around like this, and ends here at S2, or when the aortic valve closes. That is the way we look at the systolic period of the cardiac cycle. The rest of the graph here, from S2 back to S1 again, represents the diastolic portion of the cardiac cycle. So this is that systolic period we're talking about. There is a period of isovolumetric contraction where the aortic valve and the mitral valve are closed. There's no entry or exit point from the left ventricle. As the heart contracts, the pressure within the left ventricle increases. It reaches a critical point where it is greater than the aortic pressure, resulting in bursting open of the aortic valve, followed by ejection out of the left ventricle and into the aorta, resulting in a decrease in left ventricular volume. Once it reaches this point here, we begin to see the curve heading straight downward. This is when we've entered that diastolic phase, or the cardiac relaxation phase. We see the aortic valve close because the aortic pressure is greater than the left ventricular pressure. We hear the S2 sound on auscultation, and then we get a period of isovolumetric relaxation. We see a period of isovolumetric relaxation. The volume in the left ventricle doesn't change, but the pressure precipitously declines. This is the heart relaxing. This is the space within the left ventricle getting bigger and bigger as the heart muscle takes a little break. Eventually, we reach a point where left ventricular pressure is less than left atrial pressure. At this time, the mitral valve opens, the door between the left atrium and the left ventricle opens, and blood begins to rush from the atrium into the ventricle in preparation for the next systolic event. So this here is what we call the cardiac cycle. We have systole, we have isovolumetric contraction, followed by ejection phase, followed by isovolumetric relaxation, followed by diastolic filling phase here on the bottom side, where we see left ventricular volume increasing without any change in pressure. So looking down here one more time at the x-axis, we can see that end diastolic volume is represented here because this is the volume in the left ventricle right as diastole ends, right before systole begins, which is right there. And then we see here, this is end systolic volume. This is the volume when systole ends, which is right here, and diastole begins. So this difference between end systolic volume and end diastolic volume should sound familiar. It's the stroke volume. Remember, the stroke volume is the difference between end diastolic volume and end systolic volume. So if you're ever given a pressure volume loop on your exam, you're able to actually calculate your stroke volume by subtracting the end systolic volume from the end diastolic volume. Very good. So let's first spend some time reviewing the lime green curve, which is a curve that is representative of the cardiac cycle in a situation of increased preload. The first thing you should notice is that this part of the curve extends over to the right, and we see an increase in end diastolic volume. And that makes sense. We have an increase in preload, or an increase in blood flow return to the heart. We have an increase in the volume in the left ventricle at the end of diastole. It's right here. We also notice that the distance between end systolic volume to end diastolic volume is greater, which is indicative of a greater stroke volume, which is an important concept. The greater the preload, the greater the end diastolic volume, the greater the stroke volume. We can see that the end systolic volume doesn't change though. And this is important because we know that there's no real change in any of the afterload or venoconstriction or anything like that. We just know there's an increased preload. We know there's an increase in end diastolic volume. And the stroke volume increases as a result. The end systolic volume doesn't really change in this situation. So really the key with an increase in preload is an increase in stroke volume. The red-orange curve corresponds to higher contractility. In this situation, when we have a higher contractile force generated by the left ventricle, we see an increase in stroke volume. In this, we don't see an increase in end diastolic volume, we see a decrease in end systolic volume. So you think about it, the heart is able to push out more volume because it's contracting more forcefully, so that volume in the left ventricle at the end of systole is lower. And so that results in an increase in stroke volume. We see our ejection fraction increase. We also see, as I mentioned, the end in decreased end systolic volume. Now what about this last situation here, this blue situation? We have an increase in afterload. Well, first, what sort of situation are we discussing when we talk about an increase in afterload? We're talking about something like a hypertensive patient or somebody with arterial hypertension. In this situation, we have an increased aortic pressure. As a result, in order for the left ventricle to eject its volume, the pressure within the left ventricle must be greater than the pressure in the aorta. That's the only way the aortic valve is going to open. So we can see that in our period of isovolumetric contraction, there needs to be a much longer isovolumetric contractile period to reach the left ventricular pressure that is great enough to swing and push the aortic valve open. The left ventricle must contract that much harder to reach that pressure necessary to open up the aortic valve. So we can see here the y-axis is significantly increased, the pressure is significantly increased in order for the ejection period of systole to occur. You can see how much shorter it is here. You can see that in order to keep this ejection going, the pressure in the left ventricle needs to be sustained greater than the aortic pressure for longer periods of time, but the left ventricle just can't do that. It cannot create pressure for that long a period. So we can see that the ejection period, we can see the stroke volume is significantly reduced in situations of increased afterload. It's a really important concept to know and really something to think about when your patients have hypertension. Patients have hypertension have an increased afterload. There's an increased strain on your heart to create more left ventricular pressure and enter this ejection phase of the cardiac cycle. So it's important to know and think about when we talk about hypertension and the pathology surrounding it, including myocardial hypertrophy and increased myocardial oxygen demand, etc. Just talked about more in the pathology lectures. But just to review the pressure volume loop, the cardiac cycle, and in this slide we have just one cardiac cycle that goes around the loop from S1 to S1. We can see how changes in preload and contractility and afterload change our stroke volume, change our peak left ventricular pressure, change our end diastolic volume and end systolic volume. It's important to sort of remember these concepts as we go forward and discuss situations when we have increased afterload, increased preload, increased contractility. And this is the basis of understanding those disease and physiologic states.
This diagram integrates information from the atria, ventricles, jugular vein, in addition to heart sounds and the electrocardiogram. This is a very important diagram, and if you understand it well, then you have a good grasp of cardiac physiology. You'll be expected to be able to put all of this information together when you are evaluating a patient or when you are trying to answer a question on your Step 1 exam. So there's a lot going on in this diagram, so let's take a moment to break it down. First we see here the red curve, which represents left ventricular pressure. The lower dashed green curve here represents left atrial pressure. You can see the same numbers from the prior diagram represented here at the top of the graph, numbers 1 through 5, breaking down the different phases of the cardiac cycle, including isovolumetric contraction, rapid ejection, isovolumetric relaxation, rapid ventricular filling, and finishing here with rapid ventricular filling. Let's now look here at atrial systole. We can see that even if this diagram didn't say atrial systole at the top, we can see that the atrial pressure reading shows a slight increase in atrial pressure. This makes sense because the atria are contracting. The pressure increases a bit, as indicated by this upslope, and then it goes down again as the blood is pushed into the left ventricle. We can see that this corresponds nicely with the depolarization, the P wave, that is necessary to cause atrial contraction. You can see here that the ventricular volume curve goes up slightly as the blood is moved from the atrium to the ventricles in atrial systole. So now let's look at the jugular venous pulse, or the jugular venous curve. How does this correlate to the A wave in the jugular venous tracing? So remember, the jugular venous tracing is essentially pressure that is recorded in the jugular vein. So veins that are proximal to the heart. We think about the IJ in direct continuity with the superior vena cava, which is then flowing into the right atrium. So if you remember, there is no valve between the internal jugular vein, the superior vena cava, and the right atrium. So in many ways, we can see this as one continuous system. So anytime there is increase in pressure in the right atrium, it would be reflected as increased pressure in the internal jugular vein. So when we talk about the A wave, atrial contraction in the atrium of the heart results in an increase in pressure in the jugular vein. Discussed in pathophysiology, in the case of atrial fibrillation, there is no unified contraction between the atrial myocardial because they're fibrillating and they're contracting out of synchronization. In AFib, there is no A wave. There is no A wave because the atria are not able to produce a significant contractile pressure because the cardiomyocytes are all contracting on their own. With respect to the heart sounds, the left atrium is contracting to push blood into a non-compliant left ventricle so we can potentially hear the S4. That's the situation when we hear an S4 heart sound, when the left atrium is pushing blood into a non-compliant left ventricle. After atrial systole, the mitral valve closes and isovolumetric contraction begins. We can see that in this phase, both valves are closed and it is isovolumetric. So you can see here in our ventricular volume tracing, there's no change in volume. And we can see that in this period, that mitral valve is closed as well as the aortic valve is closed. This is when the S1 heart sound occurs, when the blood flows up against a closed valve. So in this phase, the ventricle continues to contract until the pressure of the left ventricle, or this red line, meets and exceeds the pressure in the aorta, which is this green line here. Once the pressure in the left ventricle exceeds that of the aortic valve opens and blood is rapidly ejected from the ventricle into the aorta. During this phase of rapid ejection, we can see rapid ventricular emptying, denoted by this downslope here in the ventricular volume curve. We can see the pressure of both the aorta and the left ventricle increasing together in concert. You can see the lines are overlapping here. We can also see that this is the ST segment of our EKG tracing. So what would you see in the JVP, or the jugular venous pressure tracing, during this time? So in the jugular venous tracing, we actually see what is called the C wave. Anatomically, the C wave represents the bulging of the tricuspid valve into the right atrium, causing an increase in jugular venous pressure. So during systole, when the ventricles are contracting, blood actually is pushed up against the tricuspid valve, causing it to bulge into the right atrium and push blood back into the jugular vein, causing this increase in pressure. When the tricuspid returns from bulging into the right atrium, the leaflets return to a normal position and we see a drop in our jugular venous pressure as the X descent. The X descent occurs as a result of more atrial relaxation and continued right ventricular contraction as blood continues to leave the ventricle out of the replacing the tricuspid valve into its normal position, and so the jugular vein pressure actually decreases here in the X descent.
Now we move on to the next part of the cardiac cycle, including the reduced ejection and isovolumetric relaxation phase.
Eventually, the ventricles start to reduce their contractile forces, they begin to relax, and the pressure in the left ventricle becomes less than that in the aorta. Remember, the aorta is an elastic artery, and it is a vessel that can maintain its pressure in comparison to the left ventricle. So the aorta stays in a high pressure environment, continues to perfuse the rest of the body. The pressure in the left ventricle begins to dip down here in isovolumetric relaxation. So once the left ventricle goes below, the pressure goes below that of the aortic valve closes, and we begin this isovolumetric period where the pressure precipitously declines. So what is this dicrotic notch here? Can you tell me or remember what this represents? So the dicrotic notch represents the aortic pressure reading that kind of looks like a V. We see a V and it is created from the regurgitation of just a small amount of blood into the left ventricle from the aorta as the aortic valve closes. This regurgitating blood pulls the aortic valve leaflets backwards down into the left ventricle, reducing the pressure in the aorta, as we see here, sort of decrease little notch. Eventually, the leaflets close and recoil, pushing forward back into the aorta as the coronary arteries are perfused. This results in that increase, or this upswing, of the pressure within the aorta. This process creates the dicrotic notch. We see a transient decrease in the aortic pressure as the aortic valve leaflets dip into the left ventricle. And we see a compensatory recoil, or increase, in aortic valve pressure as the coronaries are perfused and the aortic valve leaflets recoil back into the aorta. We also notice here is around the time of the S2 heart sound, or blood flowing up against the closed aortic valve so we can hear with our stethoscope. If we turn back to our jugular venous pressure tracing, we can see the V wave corresponds to this part of the cardiac cycle. As we accumulate blood in the right atrium, the increase in blood leads to elevated pressure in the jugular vein. So this is simply representing as the heart is contracting and there's rapid ejection, we see more blood flowing back into the jugular vein, causing this V wave, causing this increase in jugular venous pressure. Looking down at our EKG, we can see that the T wave corresponds to this period of ventricular repolarization, where the ventricle is relaxing after a rapid ejection phase. So the rest of the cardiac cycle includes rapid ventricular filling, which is essentially a period at which time the blood from the atrium fills the left ventricle, as represented you can see here in the ventricular volume curve, in preparation for the beginning of the next cardiac cycle. So that is it for the pressure volume loops in the cardiac cycle. I hope this was helpful in explaining some specifics and sort of helping integrate all of this different valuable information together. I encourage you to look at this diagram multiple times, try to synthesize all the different information and see how the EKG relates to the heart sounds, which relates to the pressure in the aorta, how the jugular venous pressure tracing relates to all of this that are going on in the left ventricle. So with that, let's continue to move on to the next segment.